Welcome everyone to our conversation from the heart. We are live streaming from Sentral, Kuala Lumpur. This is a collaboration between CVSKL Hospital and Pfizer. This afternoon we have with us next to me Dato David Chew, who's a well-known expert in heart failure. We have Dato Dr. Tamil Selvan Muthusamy, who is a well-known also senior consultant in interventional cardiology. And of course, we have Dato Razali Omar, who is the doyen of electrophysiology in Kuala Lumpur. So first I want to wish all our audience safety in this period of the COVID pandemic. And I also wish to reassure the audience that we have taken all due cares and all of us are vaccinated. So there's a greater proximity between us when you see on your screens. But we are taking all due cares and all our audience are all wearing their masks. And so without lingering on too much longer, I want to start the afternoon with a very interesting case. That the first case is to be presented by our Dato Razali Omar. Razali?
Thank you very much, Dr. Lawrence, and thank you for calling me Doyen and not the matriarch of EP. So today I'm very, very excited, and I would like to thank Pfizer and CVSKL for making this happen. Very excited to be here together with my brothers here. And one of the things that we want to perhaps show to the audience is what exactly happens at CVSKL. This is something that we do every day. So this is not going to be a didactic kind of lecture. I'm going to present a case, and I'd like my friends here to chip in. So sometimes we bump into each other along the corridor in the cath lab. They say, hey, Selvan, what do you think of this ECG? Do you think it's atrial fibrillation? And he will say, it's sinus rhythm. I say, wrong, it's atrial fibrillation. No, I'm just joking. So hopefully we'll get things started. And this is a case that I just saw last week. In fact, he's been my case since last year. He was referred to me from Malacca, where he presented with very fast atrial fibrillation, came into the hospital with acute decompensated heart failure. He was in pulmonary edema. They noted that he was in very fast AFib, so they gave him IV amiodarone and digoxin. And that night, he developed ventricular tachycardia. So he was referred to me because after they did the angiogram and found it to be normal, so they think that this is a dilated non-ischemic cardiomyopathy with an EF of 20% and with a dilated LV and LA. So he was referred for ICD. So maybe at this moment, I like to sort of, if you think, when I first saw this patient, it was like, and this is something that I see often, is a patient with heart failure and then they come with atrial fibrillation. So the question that I have always in my mind is, which is the chicken, which is the egg?
Yes.
Is it that the heart failure came first and then that triggered off an AF, and we know that can happen? Or is it that the AF has been around for so long and the patient has no symptoms and that has caused him to be heart failure?
Which is exactly what I wanted to ask you, but at this point, perhaps I will tell our audience, please join in this conversation by writing in your questions. We will, because of the flow of with the technology and all, we will discuss the case amongst ourselves, and then we will address the questions from the audience at the end of each case. So, sorry, you carry on.
So maybe before that, I mean, maybe I can try and open to the rest of you guys. Do you agree that in a patient with fast AF, maybe David, heart failure, David, and fast AF, is that the best treatment? IV amiodarone and IV digoxin?
So usually the approach would be rate control and anticoagulation. That's the easiest approach. If the patient is unstable, then there may be a role for cardioversion to try and get the patient to sinus rhythm. I think there has been some interest in trying to get back the patient into sinus rhythm and maintaining sinus rhythm. And one other approach to do that would be atrial fibrillation ablation.
Right.
But I think in the acute setting, it will probably be just to try and control the rate and get the patient out of heart failure.
I mean, so you are okay with IV amiodarone, IV digoxin? I mean, the patient is in heart failure, isn't it, with pulmonary edema? I think IV amiodarone is the safer drugs.
Yeah, among all the antiarrhythmics in heart failure, amiodarone is probably the safest drug.
Is there a sequence to which you would give the drugs? Like, do you still give digoxin first before you give the amiodarone, or does that matter anymore?
So I think it depends upon the rate and the blood pressure as well. So if the patient has a very fast rate and you want to control it quickly, then intravenous amiodarone probably would be one approach. And digoxin, I think I would prefer to use it orally, though some people can use digoxin as an intravenous preparation. But I would hesitate to give 2 intravenous drugs for rate control at the same time.
But personally, I think this is a really ill patient and a very fast heart rate. And the amiodarone might take a little longer than necessary. I'll be quite happy to give him intravenous digoxin to control the rate a bit, you know.
The other thing, of course, like Indral, Esmolol. So, I mean, bottom line, I think is all of us agree that the most important treatment at this moment when a patient comes with acute decompensated heart failure, fast atrial fibrillation, is to rate control, isn't it?
Yes.
And if you guys have IV esmolol, IV propranolol, or IV digoxin, use it, but be very careful because you have to know what are the issues. Sometimes the blood pressure drops, sometimes the patient go into severe bradycardia. IV amiodarone is what is often used. And remember, when you give IV amiodarone, the first effect of IV amiodarone is the beta blockade effect. So I think we are using IV amiodarone for its beta blockade effect. The potassium channel effect will come a bit later. So, but I think we are not so much interested in getting him sinus rhythm. Just slow down the rate and get him out of his heart failure. My dilemma here, guys, is that, I mean, he's referred for ICD. I think it's like, I was wondering, is the VT real, or is the VT triggered by the, patient is so unstable, you give IV amiodarone, I give digoxin, I'm not sure what was the potassium level and all that, whether the VT was secondary to the pro-arrhythmic effects of these drugs. What do you guys think? You think I should put in ICD for this patient?
Well, I think if I were to see the patient first, right, certainly we have seen lots of patients with ejection fraction of 20% who can be well treated, and as you know, with the newer modality of treatment, the ejection fraction can actually indeed improve.
Yes.
So I will not be really rushing in for that. But I think addressing the atrial fibrillation is extremely important. And for the audience, the reason this patient has come with a pulmonary edema is because he has an ejection fraction of 20%, walking about reasonably okay, I suppose. That is when he does not have an AF, or his heart rate is about 70, 80 beats. But the moment the AF goes up to 160, 170, the filling times are not there, the LV is not being filled up well, and that's when the patient goes to heart failure. So I would concentrate a lot more on the AF treatment and the heart failure treatment before the VT treatment.
Right, exactly.
So what happened next?
Yeah, so exactly what Selvan mentioned. I informed the patient I'm more keen to go after the AF and the flutter, and however, the question of that VT is there. So if there was no VT and it's a primary prevention case, I would definitely wait until I've taken care of the AF and wait for the EF to come up. And I've seen many patients like this. He's quite a young patient. He's only about 50-something, is it, David? Or 60? I can't remember now.
About late 50s.
Late 50s. So I have, in fact, before this case, we just turned up last week. I was actually preparing another case because there's a lot of series of young patients who present with heart failure, and the atrial fibrillation was only detected at that moment. So for those kind of patients where it's persistent atrial fibrillation, I'm more inclined, especially in a younger patient, that the atrial fibrillation is the cause for the heart failure. And after I've ablated them and they improve, and it takes about 3 months, 6 months, up to 1 year, then you see the ejection fraction and the left ventricular size get smaller and smaller, EF improve. Then the diagnosis of whether chicken or the egg is only made at the end of that period. This guy is intermittent AF. He's not in persistent AF. So I'm more inclined to think that this is more of a dilated cardiomyopathy, and therefore EF of 20%, even if he doesn't have the VT, I am a bit, I would think in terms of primary prevention. So after discussing with him, he wasn't too keen on AF ablation at that moment. He just wanted a quick one. He says, I agree for ICD. And so I implanted the ICD. And he went home. And this is what we found. The ICD was implanted about 6 months ago. And over the last 6 months, we noted these 3 things. Number one, he has atrial flutter many times. And the atrial flutter, the cycle length is 320 milliseconds. So in terms of beats per minute, 60,000 divided by 320. David?
180.
Whoa, you see, this is a product of Chinese school. 300 divided by 100, say 300. Okay, so 180 beats per minute. And this is very important for me because when we do an EP study and we want to ablate, we want to know whether what we're getting is exactly what was seen in the ICD. 320 milliseconds, 180 beats per minute. And this was quite frequent. But he had one time, last December, he came with a shock. And I thought he had VT, but when he came in, actually it was very fast atrial fibrillation, the same one he had when he presented with acute pulmonary edema with RVR, rapid ventricular rate, and it caused the ICD to think that he was in VF and gave him a shock. Of course, the shock sort of cardioverted the AF and he was well. But the shock was not for ICD, not for VT. Okay. But when he came, so I told him, I said, Mr. S, the fear, what I feared has now borne fruit. That is, your problem is the fibrillation and the flutter, which is causing you to, every time it comes, he goes into heart failure. Now, I tried giving him medications. But each time I give him medication, he went so bratty, the ICD starts to pace him. And as you know, a patient with EF of 20%, the last thing you want is pacing in the right ventricle. This will aggravate the heart failure. So I said, we either upgrade you to CRT, or let's get rid of the primary problem, which is the fibrillation. And when he came on the day that I was supposed to ablate him, we look at his ICD and the...
Can I just stop you there? Yes. Can you just explain about the CRT, because you mentioned CRT.
Right.
The upgrade.
So if you have a patient with heart failure and you need to pace the right ventricle, and we know from block HF, if you pace the right ventricle, the heart failure will get worse. From MOST study published many years ago, we find that if you have to pace the patient more than 40% and above, there is a possibility of LV dysfunction because of dysynchrony that is caused by the RV pacing. So I have to upgrade him to a biventricular. I have to, he's got dual chamber, just put another lead in the left ventricle so that I can synchronize the RV and the LV. This would hopefully prevent worsening if I need to pace him. Right. But that is like sweeping the problem under the carpet. That's what we used to do when we are not able to ablate AF 20 years ago. But I think now he finally agreed. So on the day that he came in for the ablation, and I checked his ICD in the OT, and I was as pleasantly surprised that he had flutter, and during the flutter, a PVC came in and triggered a VT, and our friend was in flutter and VT, 2 arrhythmias in one patient.
Wow.
And then so I said, so which means it justified our ICD 6 months ago.
So can I ask you, so 6 months, and what was his LV function like? I presume it's still 20%.
20%, yeah.
So despite,
he's on Entresto, he's on aldosterone, he's on beta blockers, yeah. I mean, all the wonderful drugs that David Chu will give, but I think it's too soon, and because he's still disturbed by the atrial. So I'm not sure. I don't think this is purely tachycardia-induced cardiomyopathy.
Right.
I think if we get rid of fibrillation flutter, we may be able to improve his symptoms, but the EF may... David, do you agree with that? Do you think he's like more of the cardiomyopathy rather than tachycardia-induced?
I think it's primarily a ventricular myocardial problem, and the arrhythmia is probably secondary. Some people who have heart failure can develop atrial fibrillation and atrial arrhythmias due to dilatation of the atrium. So this is probably one of these. And he presented because the atrial fibrillation worsened his heart failure.
Is there some way we can differentiate this, something maybe a little bit more objective, perhaps even a cardiac MR? Would it help? Would it have helped in this case?
Sometimes it may be difficult if it's been having heart failure for a long time. But I think if the patient just presents with early heart failure, then you can tell, because if they have heart failure as the myocardium as a primary problem, then the ventricles and atrium will tend to be large. I think if the patient has AF as the cause, then maybe the heart hasn't gone much remodeling.
I think if LV is going to dilate, there has to be constant high rate, so that means the patient either has atrial tachycardia persistent. We have seen cases like this even 20 years ago, and the heart rates are like 120, 130 all the time, and that can give rise. But in this case, it's paroxysmal, and I agree with David. This is going to be a primary myocardial problem.
Yeah.
So can I just summarize at this stage that this Mr. S came in and he had heart failure and fast AF,
Yes.
NVT,
Yes.
and the first move was to, and the coronaries are normal.
Yes.
So at that point, we put in an ICD because of our fear of the VT.
Sudden death, yes.
Plus, we were treating him medically for heart failure.
Yes.
And were we treating him
Amiodarone.
medically for the,
Yes.
and amiodarone for the atrial fibrillation.
Yeah.
But then he continued to have episodic atrial flutter.
Yes.
And this is where we are at this point.
Correct.
Okay.
Including inappropriate shocks, because despite
Yes.
the medication, but when I jack up the medication, he goes pacing. He needs to be paced. Okay, so that's where we are now.
Are you saying that the VT here was because of his atrial flutter?
I think, I suspect, because, although he's not ischemia, but the flutter was so fast that I think it reduces his cardiac output, and that triggered off a PVC, which then triggered a VT.
Right. So atrial flutter, can we say that atrial flutter and atrial fibrillation, how often does it trigger off sudden death?
Never.
Never.
Unless it's WPW.
Right.
Wolf Parkinson White with atrial fibrillation, and then patient come in, you didn't know that, and patient is given like IV digoxin or IV verapamil, and boom, we go into VF.
Except in this case.
Yeah, this case because
cardiomyopathy.
Yeah, this is cardiomyopathy.
Right.
That's right.
Okay.
If the patient was pure atrial fibrillation causing cardiomyopathy, then less likely, and that's where your question comes in. I think cardiac MRI, David, if we have the chance to do it, may differentiate it, because then there will be scars, fibrosis in the left ventricle. Maybe. Then that will be more towards a cardiomyopathy rather than tachycardia induced.
So this is a very complex case.
Yes.
Yeah, he is compromised by his cardiomyopathy with an arrhythmia.
Right.
And they're sort of related but also separate.
And this showcased a very important point. And and I'm not just trying to sell CVSKL. And this is important because no man is an island, correct? So no matter how senior you are, and all of us are so senior, and this is where you need your friend input. For me, I'm electrophysiologist, and nowadays when I fill up the form, I've been being questioned by insurance company, why do I refer to David Chu, cardiologist to cardiologist? So I said, I'm an electrophysiologist, and I don't manage heart failure. So Dr. David Chu is a specialist in heart failure. So we need to make people understand that it's not just simply we just want to, call too many doctors. The inputs are very important, because nowadays, for you to reach the top of your field, you have to be only know one thing. For me, I only know how to ablate atrial fibrillation. Okay, so let's carry on with what I do best.
Okay.
So I brought the patient, and finally he agreed for me to do atrial fibrillation, and we already discussed what we should do, and all of you agree I should bring the patient to the lab, isn't it?
Absolutely.
And get rid of the atrial fibrillation. Remember just now I said 320 milliseconds flutter, and there was atrial fibrillation. So I knew I had to go after two arrhythmias. And this is very important. Now, let me take some time to perhaps, this is the 3D image of the left atrium. So for us to do this complex type of, we cannot just base on the X-ray images. It has to help the help of the 3D machine. So for those of you who are not familiar, this is left atrium, and we are looking at the left atrium from posteriorly. It's like I'm looking at Dr. Selvan from behind, and therefore this is the left posterior wall of the left atrium, and these are the pulmonary veins. This is the left upper pulmonary vein, left lower pulmonary vein, right upper pulmonary vein, and right lower pulmonary vein. Those of you who remember, there are 4 pulmonary veins that drains from the 4 lobes, and sometimes there's a 5th one, isn't it? There's a lingular lobe on the right side. So sometimes right has got a 3rd vein, or sometimes it's just quite small. What is interesting, and for those of you who are, even those of you who are not an expert in this, I am sure you can appreciate that in this one patient, you see 2 arrhythmias at the same time. If you look at this is my catheter when it was placed near the left pulmonary vein, and I was like, wow, this is flutter. This is flutter. And at the arrow shows, and I was near the left lower pulmonary vein, atrial flutter. When I was inside the left atrial appendage, atrial flutter. And then when I moved my catheter in the right side of the pulmonary veins, and this was not inside the vein, it was outside the vein at the posterior wall, near the carina and near the posterior of the right inferior pulmonary vein, This whole thing is totally chaos. And I've never seen this. I've never seen this. It's either flutter or fibrillation. So this patient, because his left atrium was quite big, is about 4.7, 4.8 cm, the right side is fibrillating. So in the principle of arrhythmia, the fastest is the boss. So obviously, the right side, so the left side, which is organized, looks like flutter, is passive.
Right.
The ones that is spinning around and throwing off all this arrhythmia is actually the atrial fibrillation. So whilst I was mapping this, I was so excited because I'm also doing a CVSKL winter program this year, and I'm going to show all these interesting cases with all the electrophysiologists in the country. And I was so excited that I have this beautiful picture. While I was actually mapping, he changed into atrial flutter. Remember he had atrial flutter?
Yeah.
This is true atrial flutter. Those images or those chaotic signals that I saw in the right pulmonary veins no longer was there. So he actually has two types of atrial arrhythmias. One is the atrial fibrillation that we induce, and the one whilst I was mapping, it changed to atrial flutter. And for those of you who have never seen an arrhythmia in your life, this is the image of the right atrium. So this is tricuspid valve. This is the tricuspid valve. This is the SVC, and that's the IVC. Yeah? So this is in different ways. So that is the left atrium. So we combined both, and we saw this. You can see this. Focus here. You can see this. There is okay, here better, I think.
It's running.
It's running. Yeah. This one better. You can see that. So some of you have heard the word cavo tricuspid isthmus dependent counterclockwise atrial flutter. This is what it is. And you know what, like 25 years ago, when I first saw 3D, before this we all used to do SVT, 2D, and when I first saw the 3D, and you know, I remember at National Heart, I presented this, one of a senior cardiologist stood up and said, Razali, after this we don't need you anymore, because all of us can do this. Famous last words, please be careful of what you say. So this, you can see that this flutter was going around. That's the tricuspid annulus, and that's the IVC. This isthmus is called the cavo. Cavo is IVC. Cavo tricuspid isthmus. And this is where it goes up in the counterclockwise fashion. Counterclockwise, just pushing around like that. And the ablation will be from the tricuspid valve all the way to IVC, and that should terminate this tachycardia. So that's what we did. We ablated it, and you can see here, this was fluttering, boom, 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 boom. As soon as we complete the line from tricuspid to IVC, the flutter terminated. And I tell you, in electrophysiology lab, when you have termination of flutter, it is one of the most wonderful feeling. It's just like when you guys, I suppose you guys don't have that feeling, isn't it?
We always do.
Putting a stent is like nothing lah.
It's not quite, you know, when the blood flows. It's
Oh yeah, CTO. When you cross the CTO or primary PCI, and when you start establish a TIMI3 flow. Yes, you know, that kind of feeling, and that's the kind of feeling that got us waking up every day. People ask me, are you going to work? I said, no, I'm not going to work. I'm going to for my hobby. What's your hobby? Ablation.
So this, you ended up doing a atrial flutter
Correct.
termination.
So I went. So now, because sometimes we are not so lucky that this arrhythmia doesn't appear, but I know that after I've done this, it's not the end of the job. I still need to go back to the left atrium. Remember?
Yes. Okay.
So this is what we call a nice necklace lah. So when we do atrial fibrillation ablation, paroxysmal, and this guy, surprisingly, the left atrium not so unhealthy. It's not so much scarred. So I just end up doing what we call white antrum circumferential ablation, or short form WACA. So what we do is every one of these my patient asked me, what is that, balls? Huh? I said every one of those balls is blood, sweat and tears, because that represents one ablation point. Right. And you have to go around the pulmonary vein, left upper, right upper, left upper, left lower, right upper, right lower, and each of these burns cannot, it has to be 3 millimeters apart. So 1 point, and remember, the heart is pumping, and you have to hold your catheter, the patient is breathing, the heart is pumping, so things can go wrong. And this is when you need to be very careful, because one of the complications here as you go around is perforation. So one of the things that we have that makes it easy for us now is the tip of my catheter register a force. We call it contact force. So I know that if I'm touching 1 or 2 grams, the energy is not enough. If I'm going above 30 grams, then I can perforate the heart. So we know how much we are pressing. We know how much impedance drop and all those things. All the physics are there. And this gives us the best result. And I hope that this patient, after that, we try to induce.
It's not like angioplasty, more difficult. This one
This is
easy.
easier.
Easy.
Everything is on computer.
Is telling him what
Yes,
to do,
yes,
right?
correct.
Okay.
And it's just like playing video games. So when people come and visit my lab, I said, how many of you are gamers? I said, if your children play video game, do not scold them. Because one day they become like me. They become very good at this. You're just moving your catheters around. Yeah, so please.
So some mundane questions for you here. How long was the procedure time for this?
Right. So if I were to do, let's say, a normal atrial fibrillation alone, just doing that alone, now, which means skin to skin, the minute the patient, I puncture the right femoral vein and I pull out the sheath, is about 3 hours.
3 hours.
And remember, just now I just saw a patient, and he said, so long, doctor. I said, everything in life is relative. When I first started doing this, it was 8 to 10 hours.
Right.
So I said 3 hours, for you is long, but for me it's such improvement.
And the patient was under a
General anesthesia, because we put in the transesophageal echo to help me with make sure before we start is our procedure to make sure there's no clots, and also to help me with the transeptal puncture.
So for us who are not in the EP lab, so it's under general anesthetic. It takes quite a few hours. Often the patient was reluctant to do it. Was it because of some fear of some risk of this procedure?
Yes. I mean, usually before I even bring the patient to OT, I spend about at least 30 minutes to 45 minutes, because we have to lay it all on the table for the patient. Number one, unlike SVT, supraventricular, WPW, AVNRT, the chances of a cure after one procedure is 99%. But for atrial fibrillation, the best we can get is about 80-85%. If you are really early phase of atrial fibrillation, LA size is not big and no comorbidities. But when we start doing heart failure in atrial fibrillation, and we'll be talking a bit about Castle AF and Cabana and all that nowadays, 10 years ago, nobody would do AF ablation in a heart failure patient. When it was first published by Bordeaux Group, and the first author was my friend from Singapore, he was doing his fellowship there. And people will say, what? You're doing atrial fibrillation in heart failure? Are you not going to kill the patient? Because they said EF low and all that. But now we know from the Castle AF study and from the Cabana sub-study that the only way to improve the outcome, which means important cardiovascular outcome, not just symptoms, is an ablation. So in heart failure patient, it is very important that we get rid of the AF, not by medication, but by ablation.
So the other important thing is when you have heart failure, and everyone knows the beta blockers are greatest of all drugs. But if the heart failure is atrial fibrillation, the effectiveness when you look at the outcomes of patient in AF and beta blockers, patients in sinus rhythm and beta blockers, the mortality and morbidity reduction in sinus rhythm is far, far, far better than those patients in AF and beta blockers. So therefore, I could understand getting these patients to sinus rhythm does make a big difference.
Correct.
So how's he doing now?
Well, it's too soon to tell. We discharged him last Friday, David, isn't it? Last week. Yeah, last week. Of course, he came in a few days before. Very important. We don't just, this is not like an elective, come in today, do tomorrow. We brought him 2 or 3 days, and David make sure that he's prepared for the procedure, dry him out, make sure that his edema is gone, JVP is down, things like that, so that he has the best chance of a event-free procedure. And after the procedure, we kept him for a couple more days. We monitor his urine output, we monitor his everything, and once we feel that he's better, so now only time will tell. Now, because he has the ICD, I have the best, monitor. So I don't need to do Holter or anything like that. The ICD will tell me whether what we did on that last week is effective, because it will tell me whether he's there any more atrial fibrillation.
So, the questions are coming in thick and fast.
Yes.
So let's take our audience's question first. One of the first questions, just before we go to the audience question, I want to ask you is, for me in general cardiology practice and further out in general medical practice, which atrial fibrillation patients should an electrophysiologist see?
All.
All. Okay. Yes. All. Right.
Because as I said, why is that? Huh?
Yeah.
10 years, remember a firm trial? All of us grew up with a firm trial published, I think, in 2002, where it showed rate control is equivalent to rhythm management. And because of that, all the guidelines were written based on the affirm trial. And that was the largest trial. And there was no other trial for the last 20 years until recently. We have Cabana, we have Castle-AF, which I mentioned, but recently we have the East AF net, which showed that patients, if you achieve sinus rhythm early, either by medical therapy, antiarrhythmic agents, or ablation, then these patients improve in terms of heart outcome. So now we no longer have improvement in quality of life, improvement in symptoms. We have heart cardiovascular outcome, reduction in hospitalization, reduction in heart failure, reduction in stroke, and reduction in mortality. So because of that, we like to recommend, if the patient is especially young patients, and I see a lot of young patients, do not let them go into persistent AF, because once they go into persistent AF, the outcome from ablation procedure is less effective.
So maybe I'll stop you there because we have to take some questions. Yeah. So it sounds like that we have to be far more aggressive with atrial fibrillation now because of the treatment options available.
Correct.
Maybe this question.
I just want to address the second question because it's not so high risk. Maybe I was so enthusiastic. It is not high risk.
Just before we go to that, because the audience can't see the questions, so they go according to the sequence.
Right.
So the first one, we would ask David to take this question. How would you know whether the cardiomyopathy caused the AF, or the AF is a cardiomyopathy related one, or it's a tachycardia? Do you have a non-fast AF cardiomyopathy? Is there such a thing? If you have a slow AF in an older patient, would you see a dilated cardiomyopathy in this group as well?
I think we discussed that earlier. Yeah. And I think as Selvan mentioned, usually if the arrhythmia causes the heart failure, it is fast. Right. It is unusual for it to be well controlled. Sometimes it's difficult to tell if it's been for some time because the heart dilates and all that. But if the patient has a history that you know of before, of being in sinus rhythm and having heart failure and develops AF, then it's very likely that the AF is secondary to the cardiomyopathy. But if the patient presents with heart failure and AF, then sometimes we do not know which is which.
Which is first. Okay.
And only with time, if you control the AF or get rid of the AF and the heart improves, then you could say, maybe looking back, it was a tachycardia-induced cardiomyopathy.
So can I just add, is the rapid ventricular rate that causes the heart failure?
Yes.
But if the patient comes to your clinic and the ECG is 80 beats per minute, that does not mean he's 80 beats per minute all the time. You need to do a Holter at least to show that.
So the next question, which is the one that you were looking at, is firstly, it says ablation risk is so high. Yeah. That's part one. How do you convince the patient? So is that a correct assumption in the first place?
So any procedure, and I always open my statement by saying that if you go for dental extraction, there's also a risk. And I asked them, where do you come from? I come from Sungai Petani. I said, how do you come here? I took the bus, or I drove here. If I were to tell you that there's a 0.1% chance you might hit by a truck along the north-south highway, would you come out of your house? So in life, everything is a balance between the risk and benefit. So it's not so high. So I tell them, you have to tell the patient what's your experience. Don't quote other people's experience. How many have you done? What are your results? Then you can say that, well, in my hospital here, I've done this. The risk is this. So you cannot say the publication risk. This published by people who have done 10,000 AF ablation a year. So that's different. So you have to be able to be honest with the patient. What's your risk? What is and then you convince the patient because you're honest. You tell the patient, if I were to do this procedure, you might be okay. 80% of patients will be okay. There's a 20% chance you might come back with AF and I have to do it again. So, and the patient says, does it mean that I have to pay again? I say, yes, I'm so sorry. You do not pay for success. You pay for blood, sweat, and tears.
But the ablation risk itself during the procedure, it says some...
So, I've been doing this. Okay, let's talk about CVSKL. I joined CVSKL with all of you.
2017,
With,
November.
2017. And I did my first AF ablation in January 2018, on the first month that we were active. To date, I have, thank God, we have not had any complication. But the complication that I tell the patient is, number one, perforation.
Yeah.
I say, how do I prevent perforation? I said, number one is, I have all these things that I told you, the physics of it, the contact force, the
video game
most,
things.
And we have in CVSKL the most up-to-date 3D machine.
Fantastic.
And the one I show you, which means when I first started 3D 20 years ago, you guys will laugh. It's just like a balloon. It doesn't tell me that this is the left atrial appendage. It just gives a balloon. Now it tells me the root, all the folds, the mountains and the valleys of the left atrium. This kind of technology. And of course, at the end of the day, I can give this technology. They say you can bring a horse to water, you can't force it to drink it.
Yep.
So at the end of the day, it has to be also the operator.
Yeah.
So it has to be the operator and the support. And in CVSKL, as you know, we have a pure EP lab. There's no other hospital except for IGN that has a pure EP lab. In fact, IGN is not a pure EP lab because on other days, David Chu used my lab last time. So in CVSKL, my partners here use one lab, and thank you very much. I have only one lab, so I can do all these funny things. I can spend hours and nobody disturbs me. I think, and my partners who are working in other hospitals feel that is the key. When you do complex studies, you cannot afford to, I'm doing K and say, hey, primary PCI coming. I'm just doing the one pulmonary vein. I still got 3 more pulmonary vein.
I guess, and your team.
Yes, I think those are all key. Once the patient understands that, and we cannot tell, oh, don't worry, I'm the best in the country. Some say in Batam too. Therefore, no problem. No. Honesty, we spend hours with the patient. The patient usually don't make the decision then. The patient goes back. I encourage the patient to go and see second opinion, third opinion. And I think that's lacking in Malaysia.
So
you must be honest. Tell the patient, you go and see whoever doctor you want, but make sure the doctor has to be equivalent, which means EP versus EP. You cannot go and see EP and then go and see gastroenterology, whether I should go for AF ablation.
So a few follow-on questions from that is, I think you answered it as well. After ablation, I think it refers to atrial fibrillation.
ICD cannot be, okay, the last question. ICD cannot be removed because we already think that it is a primarily dilated cardiomyopathy and the AF is secondary.
Yes, but the ICD will be changed.
Yes, changed after 10 years, but not removed.
Not removed, changed. I think.
And I've not done the VT ablation. I didn't do VT ablation, I did AF ablation.
Yeah.
The patient still at risk for VT and cardiac arrest.
So they wanted to know also, someone in the audience wants to know, what is the risk of recurrence following your AF ablation?
Right.
So how many times have you done one patient?
One.
For
Yes.
a single patient, what's the maximum number you've done?
Oh, maximum number, that was in 1999, 4 times. Why? Because it started. We just started it.
So let's say now.
Now, if the patient is paroxysmal, 90% of them, one procedure.
Right.
And Selvan has sent a lot of patients to me. So he will know whether the patient comes back. Of course, there will be 1 or 2 patients which will send, but remember, if the patient, now the concept is, I think it's a very important concept, it's not cure of AF.
Right.
Reduction in the AF burden. So even you see a bit of AF here and there, doesn't mean the data that we got, those fantastic data is from the reduction in AF burden.
And even for non-electrophysiologists like myself, one thing that I've noticed that is if they have paroxysmal AF, do not wait too long.
Yes.
If you refer them early, the success rates are much better.
Correct.
And in my patients that I've referred to you, that the guys who have had failure, they've had paroxysmal AF for 10 years.
Yes, correct.
So
and LA is a bit bigger.
That's a bit bigger.
I think there was a question on the cost of these things because I think in Malaysia, of course, it's that looms large. What's the ballpark figure?
Ballpark figure, okay, so because, cost, it depends on a lot of factors. For example, this Mr. S had to be admitted a few days before and a few days after. But if it's an elective case, it's a simple paroxysmal AF, and we do just the WACA, either by cryo balloon or by radio frequency, is about 65 to 70,000 all in.
Right. Then coming back to clinical things, right? How much of AF do you think there is nowadays that is in our Malaysian type population?
That's a very good question.
And what's that main burden? Is the main burden going to be this, or still the burden of stroke?
Right. So first question is, I've been doing arrhythmia clinics for the last nearly 30 years. The first 10, 15 years of my life has been mainly SVTs. And then I think over the years, we've gotten rid of a lot of SVTs in the country. So over the last maybe 5 years, majority of, again, this is pure bias, because maybe I get referrals for AF. But for the last 3 to 4 years, my clinic, I would say 80% of the new patients are atrial fibrillation. And the second thing that is different, they are young patients.
Yeah.
This is so different from what we see when we were medical students. I remember our teachers used to say atrial fibrillation, digoxin, and aspirin.
And young, how young are
Isn't
they?
it? That's it. But I mean, I have patients. My youngest patient is 19 years old.
Right.
And 19 years old. So I said 19 years old, very funny, because sometimes in the young patient with AF, 30% of them are actually to SVT.
Yeah.
But they present with AF because SVT degenerate to AF. So for him, I went after the SVT. I couldn't get SVT. I ablated his AF. That was 2 years ago. He's well. And then his father came with him. He says, "Doctor, you check my pulse. I think I also got AF." His father also got AF. So I'm not sure whether...
I don't think this is genetic.
It's not genetic, but it so happened this is the first time father and son AF. But coming to your story, in 2019, in March, I remember this date very well because I had 3 patients, all of them between 40 to 50, all of them presented with heart failure. One of them presented with an EF of 19%, renal failure, needed dialysis, creatinine was 900, so heart failure, multi-organ failure. And the doctors was thinking about this guy needs a transplant. And then when they start to rate control him with IV amiodarone, his heart rate, his persistent AF, then they saw his EF improve from 19 to 40. They say, "Oh, wait a minute, I think this is AF-induced heart failure." So I saw him 6 months later. That was March 2019. We did the ablation, and that month we did 3 consecutive heart failure and AF in young patients between 40 and 50. I can tell you right now, I'm seeing them now 2 years later. All of them are EF of 60%. They are not on any Entresto.
I think this case is a bit more unusual with the severe cardiomyopathy.
Yes.
But in AF, I think, especially to address our audience, one of the big elephant in the room is AF and stroke.
Yes.
Right. So we must, and we'll be talking about that in the second case, which is a bit also complicated case.
Yeah.
But with AF and stroke, and I think our medical audience is really quite aware of this, the need to prevent stroke in atrial fibrillation. How do you think we Malaysian doctors are addressing this SPAF? Are we doing enough? Is the recognition of the risk of stroke enough? And are we treating to target?
I think I'm quite happy to know that I think Malaysian doctors, and I'm not saying it just out of top of my head, but I've been doing SPAF forum for the last 10 years, and one of the things we found, and this is thanks to a lot of the support from the industry, that we are able to reach out to many over 10 years, and we do 2 SPAF forums a year, not only with Boehringer Ingelheim, with Pfizer, and with Bayer. All the 3 companies have put in a lot of money to update, and I'm very proud to say that our doctors are more up to date than our neighbors. This is not from me, this is from the industry, because they have people from the other countries say, your doctors are more up to date. They use the correct dose of the NOACs.
Right.
And not 2.5 milligrams of apixaban or 10 milligrams of rivaroxaban. Not 15, 10. I was shocked. I said, where did you get the 10 from?
Taiwan.
Yeah, okay. So, coming back to your son, maybe, I'm not sure whether I have more time.
Yes.
The basic message is this: no AF, no stroke. This was taught to me by my Chinese friend in mainland China many years ago when I went to teach them how to implant Watchman. They looked at me and said, I ablate AF. I said, but how sure are you cure? No AF, no stroke. I'm not interested in your Watchman. At that time, I thought, bloody cocky. Then I realized they are on the right thing. You ablate them early, you ablate them, and you follow them up. No AF, no stroke. And this is what we know now from the ESAF net, from all these studies.
So if I can just, for the audience's benefit, you said something important. So there are stroke prevention is so important. And stroke prevention is number 1, Dr. Razali said, is if you reduce the burden of AF, if you can get patients out of AF, if you can cure them, that is the best. No AF, no stroke. Now, second is there are good anticoagulation. We will talk about that. That will reduce stroke, but it does not abolish stroke.
Yes.
It can give you a hemorrhagic stroke. Is there any other ways that you, in your patients, some of our patients that you have done, that sometimes they can't take the anticoagulants, sometimes, they are ill? What do you do?
Yeah.
And if you can explain Watchman device.
Right. So, I think the most important message is if you have risk for stroke, it should be first choice an oral anticoagulant. Either it's Warfarin or one of these direct oral anticoagulants. There are some patients, however, they cannot tolerate. Number one, the most common for me, patients with renal failure. We're not going to talk about renal failure today, but renal failure is a big problem because all the studies were only up to GFR of 30, 25, 30. That's right. We don't have a lot of evidence for below 15 and below. Yeah. That's number one. Number two is patients who have bleeding. They have bled from the GI. Number three are patients who are very fall risk, Parkinson's. Number four, elderly patients staying alone and they have memory. They have Alzheimer's, for example. So for this patient, direct oral anticoagulant may not be safe. And we know 90% of the clots causing stroke in atrial fibrillation is situated or trapped in the left atrial appendage. So the studies called PROTECT AF and many other studies have shown that if we can close off that left atrial appendage, and in Malaysia we do mainly Watchman device, and that has been shown to be equivalent to giving Warfarin. At the end of 4 years, superior to Warfarin because there's no more bleeding. You stop the Warfarin completely after 6 weeks to 3 months.
So maybe you might summarize on this.
Maybe I just like to add a bit about the patient's condition. So he was discharged on Entresto because his EF is still about 25%.
Yeah. What dose was it?
At a dose of 50 milligrams twice a day with the plan to increase it. His blood pressure is running at about 100 systolic. So if he's able to tolerate, we'll probably push it up. Secondly, he's on a beta blocker. Because his heart rate is about 60, he's in sinus rhythm. I think the amiodarone was continued to try and prevent the AF from coming back. So the beta blocker is also quite low dose at 1.25. He's on spironolactone. So these are the three drugs which are prognostic. We could consider about using SGLT2 in him because he has heart failure with reduced ejection fraction.
Yes.
He's also on anticoagulation with apixaban, 5 milligrams twice a day. This has been started even from the beginning, and I think we're going to continue this. There's a question in my mind as to if he remains in sinus, can the anticoagulation be stopped? Yeah.
So at the moment the guideline says no, because if you have CHEST VASCOL 2 or more, but because he has an ICD, so I will be N plus ICD plus. For us to be able to stop the anticoagulant, we will see the next 6 months, David, minimum, and then he will be given a home monitoring, which then will trigger that if he has AF, it will send me an email immediately, and I can tell the patient, please restart back your Eliquis.
So the ICD as a monitor.
As a monitor, right. And it's continuous. Without the ICD, without the pacemaker, I will not dare to stop. It's because his risk for stroke is so high.
Well, so the other problem we have is we have common patients that we have sent for AF ablation. They're doing so well and they've not had AF. And when I say not at AF, some of them are easy and they say, well, I used to know when I get AF. Now I don't. I absolutely know. Yeah. And they keep pestering us to stop the anticoagulant.
Yes.
How do you deal with this?
Right. So that's a good question. Now, and this is from my own patient's experience. I have a patient who does BP, and he says, I'm sorry, it is not advertisement, he says Rosmax. I say, Rosmax, very good. So he gets Rosmax, which has the ability to detect atrial fibrillation, every day, twice a day. When the Rosmax says AF or ARI, which means arrhythmia, he will use a cardia.
Cardia, yes.
And then he will send me the cardia. So there are situations where patients, if they are really invested, so if they just say, I just based on my symptom, I dare not. Yeah. This guy shows to me, and he has proven to me, and it's better than Holter. Because every day he checked with his cardia, some of them Apple Watch, and for the ministry people, please approve of the Apple Watch ECG.
Yes.
We've been waiting for the last how many years? Malaysia is the only country.
Yes.
PM, please.
So thank you very much, Razali,
Thank
for
you very much.
a fantastic case that looks at so many aspects of clinical care of all our patients who are getting more and more complicated. We have another very interesting case study coming up. For this, we'll get my Dato Dr. Selvan to present this case studies, two case studies.
Well, simultaneously.
Yes.
Thank you very much, Lawrence. It was great. And okay, this is more serious stuff. This is not
video games.
Not video games.
Not video
right?
games.
So everybody wake up, okay? Finding the sweet spot of antithrombotic therapy after ACS or PCI, if you can ever call or find such a spot. So I'm just going to quickly run through these. I have presented two cases side by side. Case 1, 45-year-old guy, chest pain for 6 hours, risk factors, only raised lipids. Case 2, a slightly younger chap, 43-year-old, chest pain of 4 hours, risk factors, diabetes, hypertension, is a smoker and known to have paroxysmal AF, never taken anything seriously, and is on very, very minimal medications, and his AF has never been well addressed. Now, so that is the ECG of the top one is a young chap who had acute anterior MI 6 hours after presentation, is sinus rhythm, and you can see the lower chap is with the multiple risk factors, and you can see ST elevation in the inferior leads. Now, I must say they are in sinus rhythm at the moment because they are paroxysmal atrial fibrillation. I'll explain that a bit later. Now, echo findings on the chap with the minimum of risk factor, only one risk factor. His LV size is almost normal. His ejection fraction is almost normal, and I believe this after the event it will get better. He has very mild anterior and apical hypokinesia during the MI period. Whereas the younger chap with paroxysmal atrial fibrillation, his LV is dilated, his ejection fraction is 35%, he has infraposterior as well as anterior hypokinesia, clearly showing what's going on in this. So this is a young man, you can see this angiogram, and this is a primary PCI, and you can see it's very nice to see this because a lot of the time we will see a thrombotic lesion, and actually you can see that is the thrombotic lesion there. That is blood clot, the haziness that you can actually see, and most often there won't be any flow. But he somehow has reperfused, but still having continuous pain, and we would go in, and it was a fairly easy procedure. Sorry, I've got to go back. Sorry.
Okay.
Well, so that was the case 1. This is the case 2, and you can see here is inferior MI is related to 1. You can see there is a branch there called left ventricular branch missing, and you can see that his RPDA is diffusely diseased, and you can see his coronaries, they've got diffuse disease, and well, he has a primary PCI, and I'll just run through ballooning here and there, and you can see reperfusion. The LV branch is opened up nicely. The PDA is also dealt with, not necessarily with stents alone, but he had stent and drug-eluting balloons in this case. And we also addressed he was stable, so we addressed the rest of the coronaries at the same attempt, and as you can see, the LV, the LAD is severely narrowed, as you can see that. Yeah, that's a very severe narrowing, and you can see that he also has almost a subtotal occlusion of his circumflex artery. You can see, well, I don't know whether you can see that. Yeah, but anyway, so those are addressed. You can see a stent being inserted into the circumflex, and to end a stent inserted in the LAD and I'll just pass that, and this is the final result, triple vessel disease. Yeah.
So I guess maybe I might stop you there. You're showing us two cases.
Yeah.
I guess they're of fairly similar age and both are ACS, acute coronary syndromes. What's the difference between the two cases, and what do you wish to illustrate from this?
Right. So the two cases are slightly different. Case one, number one, he had atrial fibrillation post-MI, post-angioplasty. Now, we often see these. So there is something that I would like to involve my colleagues here. Transient atrial fibrillation, post-angioplasty, post-myocardial infarction. They might not necessarily be a persistent. We see this all the time. Whereas case 2 is a very clear cut. He had previous history of paroxysmal AF, and even within the hospital he has had episodes of AF. So they are different in terms of the atrial fibrillation that they are presented with. Now, the other thing, there are other differences too. So the older guy has got, if you saw, it's a single vessel disease, minimal risk factors, near normal left ventricle, and Chat's vascular score is about 1. Whereas but even if his chest vascular 1 is 2, for example, I still think it's a very transient AF related to the acute insult of myocardial infarction. I wouldn't necessarily be thinking of long-term anticoagulation, the reason we are here. Whereas the other chap here, he's got multi-vessel disease, multiple risk factors, impaired LV, and his Chat's vascular score is 4. So this is how they differ. Now, so let's for
maybe we might. This is the next slide you're going to show us particularly relates to our situation here in Malaysia, I guess.
So one of the problems is we always look at the overall data of global population, and it's good that they include a significant number of Asian population within this group. So let's focus on just the Asians and in terms of AF. So in patients with AF, if you compare the Asians to non-Asians in all the major trials, we are talking about RELY, ROCKET AF, Aristotle, Engage AF, TIMI 48. And if you look at that, the stroke rate among Asian patients with atrial fibrillation are higher than non-Asians. So, in other words, that one of the things that we want to emphasize is that AF is not a very benign condition overall in the world, but if you are in this part of the world, it's even worse.
Right.
Now, but one could argue, well, maybe their Chat's vascular score is different, but then data from Asian sort of population compared to white population, for a similar Chat's vascular score, again you can see the stroke rates are higher among patients, Asian patients. So,
is there any hypothesis for why this is? Or?
Well, really we don't know, but I think that we think that we are. We are much more arteriopath in that sense. Maybe we. I absolutely can't give you a good explanation.
Could it? One of the theories I've heard before in some of the conferences I've been through is because these data based on the era before the novel oral anticoagulants. Now, in the East, particularly in the far, shall we say, in the China, Taiwan, Greater China area, there's always been a fear among medical doctors, the fear that their patients are also taking other medicines, particularly traditional medicines. Now, so I wanted to ask you what you think of the what is this related to Warfarin in the era when doctors were patients were most of the time below the level of the recommended INR, and is it really that there's an increased bleeding risk in Asian patients, and therefore we have to be more careful with Warfarin and maybe the NOACs?
Yeah, I think that's a brilliant question. Let me run through how does this differ in Asian population. Now, if you look, the event rates stratified by Chat's vascular score, and the higher the ischemic, the Chat's vascular score, the more profound is the risk of stroke. You can see per 100 person year, it's a remarkable incremental rates that you see. Now, you must also understand the higher the Chat's vascular score, so is the higher the bleeding rates or the risk of bleeding in these patients. Now, so obviously, this we always look at another aspect of preventing thrombosis is how do we balance this with a bleeding risk? That is, in my opinion, there is not a single bleeding risk categories or data that we can use to accurately assess that, but a bleeding risk such as has blood does help. Now, if you look at patients, and in particular to your question, if you look at patients on warfarin among Asians and non-Asians in randomized controlled trials, and you can see that the stroke rate in patients, Asian patients taking warfarin is much higher than non-Asians. Somehow, we don't know whether the warfarin is not working so well, you can't quite say that, but it's just the data that shows that. And even worse, we are talking about when they're on warfarin, they are getting more stroke, ischemic stroke and systemic embolism. But look at this, and this is the biggest thing. The one that we worry terribly is intracranial hemorrhages. And you can see that the Asian population has the worst outcome in terms of intracranial hemorrhages when they are on warfarin. So this is indeed events on warfarin in Asians versus non-Asians in randomized trials. In every trial that you look at, in the 4 major trials, that intracranial hemorrhage was much higher among Asians in all these trials. So the Asian population, as in AF, seem to have a higher risk of stroke when they're on warfarin, and the higher risk of hemorrhage, intracranial hemorrhage, when they are on warfarin. So you can't quite say that warfarin is maybe not effective for them to prevent thrombosis, but it seems to be giving them more bleeds as well. Now, and one could say perhaps that Asian population is at risk because, you know, we use the oval global white men's, if you like, INR targets. But then if you look, even when the INR levels are at a lower range, the major bleedings in Asian patients with warfarin is higher. So we are, as a group, susceptible for bleeds with warfarin. Now, if you look at all the 4 randomized controlled trials, intracranial hemorrhage in Asians versus non-Asian patients, and you can see NOACs are far better. So one thing for sure, all the trials have shown in terms of warfarin versus NOACs in preventing stroke in AF patients, they are equipotent, except perhaps very high dose of Pradaxa 150 BD, where it was shown to be superior. But in terms of bleeding reduction, NOACs beat warfarin flat. So I like coming back that it is the net benefit that we are talking about. You got to reduce stroke and you shouldn't have too much bleeding. And I think that is how a sweet spot comes along in patients, but not quite my patients who have had MI. So what about stroke and systemic embolism? And you can see here, the earlier data was hemorrhage, and surely NOAC was better. And this data shows that NOACs are generally equipotent to warfarin in producing event present. So now my question, my task is, sorry.
Yeah, sorry. So before we go to words, can I just, I was involved with the Asian, in fact, we published the Asian Rely with a group of the Asian Rely investigators. And in answer to what Lawrence bring up, number one, we found that just talking about intracranial hemorrhage in Asian patients, The thing that was a bit funny was Asian patients tend to be younger. You expect younger patients to be less intracranial hemorrhage. So Asian patient younger. Blood pressure control was excellent. The INR tends to be most of the time lower. And that explains why the Warfarin group has a higher stroke in Asian patient, even no matter how good we try. In the RELY study, only Singapore and Hong Kong reached 67% and above.
TTR.
All of us were
Below.
about 50%.
50%, yeah.
In spite of younger patients, good BP control and
Low
INR
INR.
lower, the intracranial hemorrhage was
more.
2.4 times higher
right.
in the RELY.
There's
And there was
something else.
and something else. And it is nothing to do with INR, which is above 6.
Right.
Most of us, when we have a patient in emergency, INR is 6, we all panic, we think he's going to bleed in the brain. We have seen intracranial hemorrhage in INR of 2, 2.2.
Right. Right.
So one of the hypotheses, and this was a hypothesis by a neurologist that I met, and he says that if you think about Warfarin blocks intrinsic, extrinsic, and common.
Yeah.
All of us, as we grow older, tends to have a bleed. They have amyloid changes in our brain, and we bleed. Small bleed. It doesn't have any clinical impact. If you go on Warfarin, you block all the 3 pathways.
Right.
That bleed becomes a bit more.
So something that we are not calculating, not accounting
When you
for.
give NOACs or DOACs, you block only one pathway. So the other pathway is not overwhelmed.
Yeah.
Right. Good. Good.
Yeah.
Yep.
That makes sense.
I just want to ask about the low CHADVAS score, 0 to 1. Generally, it's recommended no anticoagulation.
No anti.
But since Asians have higher risk of stroke, do you think that there is a role for anticoagulation?
Actually, I was going to say, I was going to say age.
Yeah.
Selvan showed that Asian has higher risk for stroke. The CHADVAS score is based on the Western epidemiology data, 65 and above. The Taiwanese, Koreans, and the Hong Kong and the Chinese have published recently that in Asian patient, 55 and above has a higher risk for stroke. So therefore, in answer to your question, David, not only the 0.1, so when you see 0.1, based on the CHADVAS score of 65 and above.
So change.
Now, if I have a patient who is 60, I would tell the patient, if I were you, I'll take it.
Okay. So in addition to that, I think when I see a patient with a CHADS vascular score 1, we are talking about male, right? 1.
Female.
Male. No, I'm talking
Oh,
about
male.
a male
With
who
one.
has with a score of 1 that is based on the CHADS vascular score that is global. But now the modified CHADS vascular score that he's talking about is they've brought 1 point to patients who are 54 and above up to 65. So in other words, that answers. But I think you got to think deep and look into your patient. And there are patients who have only CHADS vascular score 1 male, patients with 1, we would consider anticoagulation.
Carry on. Yep.
Now, so let's focus on, here's a patient who has said, all the time we're talking about patients who are stable, who have AF, and we talked about Warfarin, we talked about NOAC. Now, what happens then when these patients now have to come in for a procedure, angioplasty procedure, let it be acute coronary syndrome or elective procedure? What happens? Now, I think not many of the younger people will realize we are not that old, but when we started angioplasties, it was Warfarin and Aspirin. And the groins used to look like a dog's meal. We have to press on the groin and they're all bruised and they have to stay in the hospital for so many days. Now, and how do you treat a patient who has got AF and he needed a stent? Now, just to clarify, if the patient is in sinus rhythm, when we put a drug-eluting stent or bare metal stent, we give them dual antiplatelet therapy. Now, the duration of which one can argue, in some patients, if bare metal 1 month dual antiplatelet, in drug-eluting you can be saying 6 months, 1 year, or even longer depending on the clinical scenario. Now they have AF. So before the NOAC data was strong enough, most of these patients received Warfarin. And this is a very interesting data, a WAS trial, which looked at a small group of patients. So if you can see here, in this arm here is triple therapy. What does triple therapy means in this particular trial? Warfarin, an antiplatelet, clopidogrel, and aspirin. Now, and if you look at the lower arm, they are dual therapy. In other words, warfarin and no aspirin. And this is the endpoint, bleeding events. And you can see that actually adding on aspirin was giving more trouble. Look at the bleeding rates on triple therapy. And if you look, obviously one has to be very careful about looking at ischemic events because it's a very, very small number and I don't think you can get huge statistical analysis, but you can actually see that the dual without aspirin,
It's not worse, lah.
it's not worse. That's all you can say.
There's no signal to say that
There's
you
no
got more
signal.
stent thrombosis.
So one of the things that we learned is aspirin being aspirin, it's when it's added on, it does give trouble. Now, but maintaining warfarin in these patients are not easy.
But without the NOAC, you have to give aspirin, isn't it, after stent?
Absolutely. But now, when the NOACs came into market, to address this issue of patients going into PCI, stenting, the first publication was Pioneer AF. Now, what I want to show is how confusing all this data and how it did not help clinicians to answer their questions. What do I mean by that? In this Pioneer AF using rivaroxaban, you can see group 1, they had rivaroxaban 15 milligram plus clopidogrel or prasugrel or ticagrelor without aspirin. Now, my problem number 1, Dr. Razali is going to tell you, hang on a second, in the trial using rivaroxaban in stroke prevention, it was 20 milligrams and 15 milligrams was only if your GFR was below, I think it was below 50, right? So, first of all, it doesn't answer my question.
Right.
And we are talking about reducing ischemic event in a patient with stent, but we're not addressing the stroke events that's going to happen. So, confusing.
worse.
Yes. And then if you look at group 2, you will see rivaroxaban 2.5 milligram twice daily. Now, that came from Atlas trial,
Yes.
where in patients who had acute coronary syndrome and adding on a very low dose showed to reduce event. But again, we are not only trying to prevent coronary event, we are trying to prevent stroke event, making us even more confusing. After several months, they
back to
go
15.
on to 15 milligram and low dose aspirin.
Aspirin, yeah.
And finally, the last group is aspirin, warfarin plus dual antiplatelet. So in this particular trial, it's so confusing because not an apple to apple comparison, and none of the doses that were used except for warfarin were inconsistent with our primary or aim of stroke prevention. Now, and if you look at the Pioneer AF results, it was basically, it said that maybe if you used a low dose rivaroxaban and a single antiplatelet, there were less bleeding risk. But the ischemic risks were never addressed in this. So the question is the implication of WOST and Pioneer as shown about the aspirin. What is the purpose of this aspirin? But we have not completely gotten over it. But there are other trials of NOACs in PCI patients. Now, I'm going to quickly show you 3 different trials. Again, we have a problem. If you look at redual PCI using prasugrel, group 1 is high dose dabigatran, clopidogrel or ticagrelor, fair enough. Low dose dabigatran with clopidogrel or ticagrelor, but then look at your other. It's warfarin, clopidogrel or ticagrelor and aspirin. So here we go.
But that's standard. That's the standard.
That's dual therapy and then again it's a triple therapy.
Yes.
It may be standard, but the results cannot then be directly compared. But
No, because that is the current practice before the... see, when Redual and Augustus, the guidelines was triple therapy.
Sure, right.
Yeah.
So
that is standard
even in
therapy.
2016,
Yes.
it's also triple therapy. Now, but then if you look at Entrust AF-PCI, and this trial, again, edoxaban 60, no aspirin with P2 dual therapy, warfarin with triple therapy. Now, and if you look at the the one that helps a clinician the most, this is the cleanest I could see. Augustus, apixaban 5 twice daily against warfarin, and then divided between placebo, aspirin, and please stop touching
myself.
touching myself.
Yeah.
All
the
right,
audience is offended.
Oh, I'm sorry. I won't touch myself. Now,
Okay.
all the time I was thinking when they're showing, I thought as time's up, I said, oh, I'll hurry it up. No, so,
Oh, go on, go on.
okay,
Sorry.
I tell you what I like about Augustus. As a clinician, it gives me clear guidance. What it shows is that let's compare apixaban and warfarin, and let's compare them with dual therapy or triple therapy. In other words, apixaban, P2Y12 antagonist, whatever it may be, clopidogrel or ticagrelor.
90% of them were actually clopidogrel in all the studies.
Yeah, 93% in this case. Warfarin with clopidogrel, whatever, and then either with aspirin or no aspirin.
Right.
So, and for me, it is clear message that it shows. So I particularly like this, and so basically in patients with AF and ACI or PCI on P2Y12 inhibitors, they had these two independent hypotheses. Apixaban is non-inferior in preventing thrombosis or hemostasis. Single antiplatelet therapy may be superior to dual antiplatelet therapy. That is a simple question. And the other important thing about Augustus is these are patients with acute coronary syndrome, and they were either treated medically or emergency PCIs or even stage PCIs. Now, so this we know, very clear randomization, 4,600 patients. Primary outcome, as always, will be the major bleeding, clinically relevant, and the secondary outcomes will be death or hospitalization or ischemic events. Now, the important thing here is that these trials, it's a secondary outcome, because if you need to prove that, you need a lot more patients in the trial. And this is how the data looks. If you look here, that highest bleeding rate is when triple therapy. That means warfarin, aspirin, and another antiplatelet. Then, second is Novak apixaban and DAPT. And if you look, then warfarin and one single antiplatelet was better than a Novak with 12 antiplatelet. And finally, the best result was seen when apixaban was used with a single antiplatelet agent without warfarin.
Sorry, can I just without aspirin? So single antiplatelet has to be P2Y12.
Yes, P2Y12.
That's right.
The single antiplatelet.
So it cannot just be any.
Oh, no, it can't be. So we are comparing. P2Y12 is a must. Everybody has it, whether they have aspirin or don't have aspirin. So if you are on apixaban, if you're on P2Y12, clopidogrel in 90% of the cases and 7% were on Brilinta or ticagrelor, and they were superior to any of the combination. Now, the reason I like it is, I'm sure that not so clever computer game doctors will see it easy like this, we know everything straightforward, right? Now, so what about death and hospitalization? Again, you can see that here slightly different. The moment you're on warfarin, death and hospitalization were higher. Doesn't matter if you're on double or single. The moment you're on warfarin, you're worse in terms of death or hospitalization. What about ischemic outcomes? Now, we must be careful about this because that numbers are small, that primary objective, the statistical significance might not be. But if you look at death, it doesn't seem to be, you see a wide interval, a hazard ratio, but you could see stroke with apixaban was lower, statistically significant, and hospitalization was lower. So in this ischemic outcomes, you could see that a NOAC in this particular trial with apixaban was superior to warfarin. What about aspirin or without aspirin? Well, it didn't really, individual ischemic events did not highlight any significant difference. All we can say is not worse off if you were on placebo.
I mean, you don't need aspirin.
Can I just ask you there, is that something new though? Is is this finally a NOAC actually showing that it actually reduces is superior to VKA for stroke prevention?
So I think that
Or is
the
it too
take-home
small?
message,
No,
the
it is
take-home
not-
message is that
It's not tested for stroke.
stroke.
Prevention.
Ischemic
It's
is-
a secondary outcome, so you can't make that conclusion.
You can't make that
because of-
conclusion. But the take-home message is that any benefit that you need to get, you have a net benefit. So we know that a stroke reduction, with a proven dose, it will work, but it is always countered by bleeding risk, particularly when you have a triple agent. But this tells us that the net effect will be better if you get rid of aspirin.
Yeah.
And you should get rid of warfarin, clearly. So,
Hang on. Go back to the previous slide.
sorry.
So one of the things that concerns me a bit, especially if the patient has ACS, the ischemic outcomes, is that if you look at the aspirin against placebo,
Yes.
the trend to ischemic outcomes all seem to be lower with aspirin. You see 3.1 versus 3.4 for death, 2.3 versus 2.5, myocardial infarction 2.9 versus 3.6, definite or probable stent thrombosis 0.5 versus 0.9. But of course, they are not significant because the numbers are small. But that makes me wonder, maybe you still need aspirin if the patient has high risk, for stent thrombosis or high risk of ischemic event.
So to answer that, I will say that first of all, in this data, we cannot make that
conclusion,
simplistic conclusion. Now, I could take you away from that and let's talk about a Korean trial looking at post-PCI, and these are not patients with AF necessarily. These are not patients with NOAC.
Yeah.
Then they made a comparison of single antiplatelet with Brilinta or ticagrelor alone and versus aspirin and ticagrelor. And the message that got across is the bleeding risk was significantly lower, as you would expect, but the ischemic risk in that trial was not significantly higher. And in fact, statistically, there were quite reasonable results that would say. Now, if you take TIMI's trial in diabetic patients with PCI, we get a similar sort of trend. So I think it's a balance. One thing for sure, David, that the more antiplatelet and NOACs that you give, the less will be the ischemic event for sure. But it is about balancing it. And I think that whatever benefit that you may get, you are going to lose on the bleeding risk. So it's a net effect that we're talking about. Right. Now, the conclusion here was the patients with AF and recent acute coronary syndrome or PCI treated with P2Y12 inhibitors that included apixaban without aspirin resulted in less bleeding, fewer hospitalization without significant difference in ischemic event. Obviously, we take caution about the word significant difference because the trial was not designed to answer that as a primary objective. But certainly, we didn't see it worse.
Now, sorry, one of the things that maybe you did not emphasize is how long was, all these patients, Redual and Augustus, all had triple. Because when the patient comes in the cath lab, all of you will give aspirin, clopidogrel, and the patient is already on the NOAC, correct?
Yes.
So in the Augustus, how long was the patient on double antiplatelet before you had to stop? Because the trial mandated that you either...
12 months, right? 12 months was the total.
Double antiplatelet.
Double
Before
antiplatelet.
randomization.
Yeah, before randomization.
So the randomization, average randomization period that occurred here was, I think it's about 7 days before they
So I think that's a very important point because even in Redual, so all the two trials, I'm not familiar with the other one, but the Redual and Augustus, and it's very important because this drove the ESC guideline 2020.
Yes.
1 week. And my question is, how comfortable are you guys after a stent to stop aspirin after 1 week?
Let me tell you, I will be very comfortable to do stenting without any aspirin.
Let's say you do a rotablator and you put 5 stents.
Yeah, I've done a left main and the patient has a problem with the aspirin allergy. I'm happy to do that.
Right.
I give them ticagrelor rather than Brilinta. if prasugrel was
single antiplatelet?
because the patient is allergic to aspirin, right?
Because, okay, you understand, but I have asked this to many interventionalists, and they, although there is, like what I think Selvan is going to mention about the ESC guidelines, the latest one, but in reality, not many interventionalists would be very happy. In fact, we took a survey that was in Twitter, and 60% of them are quite happy. The other 40%, maybe like David, he's a bit worried about the instant thrombosis. So he's not willing. So no, they adopt Augustus and Rodrigo, but they said maybe 1 month. So this is something that I want you guys to think about. Like what is the shortest duration you are comfortable, and what sort of situation you will say, I'm not comfortable even 1 month?
I think, I'm sort of a generalist here, rather than a super subspecialty cardiologist or interventional cardiologist. I think from what I can see, and Selvan saying what he says, there's a reason behind it. It's because of also partly his experience in terms of the intervention itself.
Yes.
Yeah. So because he's very confident of the intervention, therefore he feels very confident to apply what has been mentioned in Augustus.
Yeah.
Yeah.
I think he's got a point. Two things, right? By no means I'm saying I'll never use aspirin, right? So there are circumstances when I'm confident not to use the aspirin. But if I'm going to do the angioplasty, I'm going to base the angioplasty on intravascular ultrasound.
Yeah. So
I'm going to make sure that the stents are well opposed. I'm going to make sure I got the best result. So you can't just do it without.
So that's the key.
That's the key.
That's part of it. That's what I'm getting at.
The question is, when was the last time you guys saw an instant thrombosis, acute stent thrombosis?
Oh, thank God.
Touch everything.
Because I think I asked this question. And what David fears, in reality, is so rare, David. I know that because all of us are old school, when we started angioplasty, including me, instant thrombosis was something that we saw because we did not prepare the lesions properly. We put in a smaller stent. We did not oppose the stent to the walls. And we had a fair number of instant thrombosis, correct?
They've changed so much.
When I asked the interventionists, and they think about it, they said the last time I saw an acute stent thrombosis was maybe more than 10 years ago.
Yeah.
So in reality, David, what you fear is something that is very rare, especially if you do the job well.
Yeah. In the Synergy trial looking at stent thrombosis, 12-month period stent thrombosis is almost 0%.
Right.
And the 2-year stent thrombosis were like 0.01% or something. So it is a rare event. We shouldn't be worried about stent thrombosis.
So therefore, when you guys do interventional PCI in a patient with a known AF, knowing about this issue, whether you are going to give single week, 1 week, or 1 month of double antiplatelet with a NOAC, then you will have to, do you recommend IVUS in all patients?
Well, I think if I'm going to do a left main stenting, complex lesion, rotablators, and if I particularly think that bleeding is going to be a problem for this patient, I will certainly use IVUS.
Right.
Now, in this particular patient, right, David is right just now when he questioned, the numbers are
numerical,
not quite...
Those are numerical differences.
But the more the antiplatelet you give, the less ischemic. That's taken for sure. So, in this patient, that I might give aspirin. Why? Because if I look at the chap and I say his bleeding risks are really low, then I'll be quite happy to give the aspirin as a triple therapy. So
what do you do with the two patients?
Okay, the first patient, he had no NOAC at all. Now, I must say, I have never given Warfarin for years now for any of my atrial fibrillation patient. I think all of us will agree that. Now, so the first patient, why I did not give NOAC? Because it was a transient AF. He is got low risk factor. Now, on the other patient, you can see that this patient had Cardioprin, Brilinta, and Eliquis. Although I said I'm quite happy not to use, I did because his bleeding risk is low.
Just for 1 week?
By when the time he came back for the follow-up, because in the trial, there was a 7-day period. Yeah? So when he came back for the follow-up, in this case 2 weeks, his cardioprin was discontinued.
Perfect.
As you can see.
Let me just ask you, if the first patient, transient, 65 years old, are you quite happy not to give him? Because you don't know transient,
Sure,
maybe he
okay.
had it before.
So if he was 60, this guy was 43 or
Yes.
45. He's 65. I will be giving him,
okay.
give him until I'm quite
For
clear.
sure, there is
For
no
sure,
reaction.
yeah.
That it was because I think I just want to be clear that transient AF may be transient, but it may be that it's the manifestation of AF that he had before, and the ischemia manifests AF. So when we say transient, how sure are we it's transient? You can never be sure.
That's right,
So
yeah.
if the risk factor is high, I would support NOAC until we know for sure.
Yeah.
But here I agree that it is very young patient, so the risk is so low, and the chances of a bleed is so high. This outweighs.
So we'll
benefit.
still support back the Ministry of Health approving the app
Please.
on the ECG.
Please.
The ECG app on the watches.
So this is the old guideline, you know. So you really have to look at low bleeding risk and high bleeding risk. So all of us most of us for some time now have been giving triple therapy not more than a month.
Yes.
Not more than a month. Then your dual therapy depends on your case to case. If you have a low bleeding risk, and if you think like Razali asked, chronic renal failure or with GI bleed before, of course you're going to reduce the dual therapy shortest possible.
Yes.
But if you're a young guy with a low bleeding risk, a left main LAD stenting, multi-vessel stenting, then
Yeah.
I am quite happy to continue that for a year, following which they'll be on monotherapy.
Monotherapy.
That will be your
Anticoagulants?
NOAC alone. So that is what.
Yeah, so I'm glad you say that, because I can vouch that a lot of other cardiologists, they are not happy to do that. They insist that patient, even after 1 year, will need antiplatelet. What do you guys think about that? Because I have a lot of patients, and I will write to them. I said more than a year, guideline says you can stop the Plavix or aspirin, go on only on NOAC. But they said no, he's got coronary artery disease. I'm not comfortable. I want antiplatelets.
No, I do
So
not-
how do you convince your colleagues?
So I tell them that.
Tell them that
What is
Razali
the-
will come after you.
Yeah. No, I think the answer is this, right? So they've grown up thinking that you need this antiplatelet,
yes.
right? But if you look, and if you ask them, they actually will talk about, delayed stent thrombosis
Correct.
and all that.
Correct.
But it's such a rare event. You're going to increase bleeding risk, so therefore you should.
Yeah.
Unless in some patients, the bleeding risk are so low, but the ischemic risk, for some reason, they've had recurrent
Right.
acute coronary syndrome. You have diffuse disease,
Yes.
and you know that they came back with recurrent even despite your monotherapy. Then it makes
Correct.
a judgment call
Yes.
that you think that, well, I can justify the bleeding risk.
Right.
But by and large, for most patients, you don't have to.
Right. So, and that's the reason why, Lawrence, I don't go after them, because at the end of the day, everything that we present to you is dependent upon the operator and the case. We think that if possible, 1 week of double antiplatelet and stop. But there are some patients in whom you are not comfortable. And I will tell, like what I told my colleagues, let's say you're comfortable with 3 months. You say, I want double antiplatelet because I put 5 stent, I rotablated this guy, and one of them was 2.5 millimeter stent. I'm not comfortable. So give your triple until one day the patient bleeds, for example. If the patient don't bleed for 6 months, you're lucky.
Yeah.
Carry on your 6 months. If the patient bleed, you can fall back on the data and says that I'm now compelled to stop. I have enough evidence that I feel it's safe. Your bleeding risk is high. So I think that's how we should approach it, and not just like there is a guideline and therefore everyone should stop, and 1
Yeah.
week everyone should ask. So you all must look at your patients, and I never make the decision. I will call the operators. I will ask them who put in the stand, are you comfortable? If they say they're not comfortable, we will carry on the double or the triples until they are comfortable. So it has to be a discussion with the operators.
So thank you very much for the 2 cases, because they help me, I'm sure help the audience as well, to sort of some clarification, because it may not be the final answer to
Yes.
things ultimately, but it is easier for work. So that at least I am more clear in my approach that I should be using a single antiplatelet. Like, the 3 arms of the trials with rivaroxaban have left me. I keep I keep having to look back at the chart to decide which one I want.
Stop looking.
So we'll stop looking at that.
I think the Pioneer, to be fair to the investigator, it was just mainly as a pilot. Soul searching.
Yeah. For sure. So anyway, this helps a lot. And perhaps I'll throw this to.
It's so clear that there's no question.
I mean, this is how. That's what I say. This is not video game. So clear, no questions.
No question. But I have a question.
Can you just make sure the audience are still there?
I have a question to David, because I said we are talking so much about the NOAC and the Warfarin, and we are talking about PCI in this setting. But then it comes back to the primary thing is the setting. The setting is atrial fibrillation and the risk of stroke. So can you tell us what's the statistics like for stroke and atrial fibrillation at this stage? Like what's the big deal about this Warfarin and this NOAC? How bad is the stroke burden?
So in patients with atrial fibrillation, I think the concern is that they can get a clot in the left atrium that embolizes to the brain and leads to a stroke. And therefore, there is a role for anticoagulation, which will reduce the risk of stroke by about 60%.
Right.
If you anticoagulate the patient. And then I think the trials have suggested that NOAC has better safety because it has less bleeding risk. So that's the reason why the move to it. And the risk of a stroke increases if the patient has more Chadwick's factors.
Yes.
So we know all this, and if the patient doesn't have much risk factors, sometimes we do not need to anticoagulate them. So Selvan was making it a bit more complicated by the fact that the patient had ACS and PCI. So with the need to use double antiplatelet in that setting, but he has shown that it may be safe to basically drop aspirin.
Yes.
Because the risk of an ischemic event that you reduce with aspirin is quite minimal benefit, and the risk of bleeding is substantially higher.
Yeah, so the fundamental thing is still that these patients with AF, and the AF burden is becoming more and more. A lot of the general population still does not understand AF, has not heard of AF. Whenever I tell them AF, very often it's the first time they heard of AF. But having said that, quite a lot of people now, more and more people know about AF now. And the worst thing about AF, again, always is stroke. So since there are no questions, can I pinch the pointer from you?
Yes.
Thank you.
Thank you.
So we'll go on to a case, and we'll see how much of the case we can get through. This case, case number 3, is about a patient. He's relatively young. He's 47 or 48 years old. Let's get it. Can we put it on the slide? Yes. So this chap, illustrates quite a more mundane. Mine is not so complicated like Selvan's case and Razali's. It's much more mundane kind of case. He presented in November of 2019. Right, he's 47 years old, very tall, strapping sort of person, smoker, and not fat, really almost athletic in his build. No significant past history. His father was a diabetic and had bypass, and he was under my care, so he came to look for me. But his story is this: he developed cough and hemoptysis after travel. And he was admitted to another hospital in end of 2019. And he was diagnosed as having a sinus retention cyst. He got treated and he got well, but he kept getting breathless. And every time he was breathless, he would go to a clinic. And because I think the diagnosis was established, he was always treated as having sinusitis and asthma. So he came to see me, sorry, that was 2018, I wrote that wrongly, 2018. He finally came, he was ill again in October of 2019 and presented to us in November of 2019. That's a full year after his symptoms developed, again with a dry cough, no wheezing, breathless on exertion, but this time he could not lie down and he said he felt bloated. And by the time he came to see me, he was actually tachycardic in the clinic. His blood pressure was all right. His saturation was 100%, but listening to his heart, he had a good going gallop, third heart sound, third S3 gallop, but he had no leg edema, right? And his JVP, we could not see his JVP again. So these are things that the main thing that struck me was that he was tachycardic and that he had a third heart sound. Then we did the normal things in clinic. This is actually the ECG from a year ago. But it is the same ECG, but he was tachycardic. Yeah. So this ECG showed him to have Q waves in the anterior leads, anteroseptal leads, and also in the inferior leads. And this was his X-ray in when he arrived, which shows the very enlarged heart and the bat swing appearances and the upper lobe diversion. So, clinically, he was in failure, and his X-ray confirmed that as well. So we did an echo. David, you're the echo expert. Would you like to comment on this echo?
There's a global hypokinesia, and I think there's a bit of mitral regurgitation. EF probably about 30%.
Even less.
That day we measured, the measure
20?
from was only about 14%.
Yeah.
A very low thing. At this point here, David, what you said global, but with the Q waves, what do you think?
If you go back, was there an apical sort of, hypokinetic area as well? Whether there must be an ischemic component, Okay, can you, what do you think, David?
Just go this one.
It doesn't play.
You go back one more.
Go back one more slide.
Okay.
Go back
One more slide. And then come back.
And then come back, yeah. Okay.
And maybe not here. You can see
So
on
the
the
basis-
panel on the left,
On the right as well.
on the right, yeah.
Apical akinesia.
akinesia. So
The rest is very weak as well. So,
Yeah.
so in fact, my thoughts at that point were that it was a global thing. He looked quite well. He was a smoker.
Yeah.
But he really looked, if you just looked at him, you would have said it was sinusitis.
So 2018, no Q waves.
No, he only came to see us in 2019.
Oh.
So I don't have old ECGs.
Right, yeah, right.
His father was my patient.
Right.
And he came to see me.
I suppose
he-
his father's ECG did not help his ECG.
His father's ECG was not very
like his
good.
case.
So his ECG, these are his findings. His ejection fraction we calculated at 14%. The pro-BNP level was 3834 when he came in. His creatinine was already borderline. His LDL was high. And I sent him for a CT angiogram.
Sorry, can I just ask David? 3834, David, is it consistent with, I would expect like 20,000 in this
He's a
kind
young
of failure.
guy.
But 3834 is not very high.
It's high.
It's
Very
high.
high. It's high.
But do you expect it to be higher?
No, I think the patient has very severe heart failure. It can be very high, but in the patient who has acute heart failure, I think above 1,008 would be
So it's not like a linear regression curve.
You're talking about EF and the
No, I'm talking about this worsening heart failure
clinical
correlation.
situation and
If I
BNP.
see, let's say I don't see the patient and you show me a BNP of 20,000 versus a BNP of 3,000. I would say 20,000, the patient is in trouble.
Age. I think I'll say age is a major factor for him at about 40 plus and otherwise fit looking sort of person. 3834 would have been pretty bad.
Got it.
I think it's difficult to make that correlation because I've seen patients with heart failure with preserved ejection fraction at 24,000, 28,000, right?
So what is the reason that patient is 20,000 and this patient is 3,000? Because I'm a simplistic mind. For me, it's like higher the BNP, the worse the heart failure. But you guys are telling me it's not.
No.
So it cannot be used as a guide to us.
It's a guide. I would
Yeah.
say it's still a guide, but
Say individual guide for a particular patient to
Patient
look
also.
at that trend coming
Okay,
down.
got it.
we can also track it. Yeah. So I said I thought he might be actually an idiopathic or cardiomyopathy. And so I thought I'll just do a heart scan on him because I didn't want to put him through any invasive procedure. And it came back as being very high. And because the calcium was concentrated in certain areas, and I decided that I wouldn't proceed because I would really need to know his coronary. So I stopped it at the calcium score and I didn't proceed with any contrast. but also because his creatinine was a little bit borderline. So next was, this is his angiogram.
Oh, why?
So it shows here that the circumflex is occluded, and then he had really severe disease in his proximal left anterior descending artery, which you can see is actually here is actually occluded as well. So he had occluded his left anterior descending and his circumflex, and this is his right.
How old is he again, sorry?
47. 47. So, so at this point then, I'll just carry on with his history. This is his, just to, in the interest of time, I won't show the running films. But he had, so basically he had a very poor ejection fraction,
right.
And he had severe triple vessel disease.
With Q waves already.
Q waves.
So is it viable?
So is it viable? Yeah. So, but I think for a young person, right, I'm not sure whether
you need viability.
this is so because he has a severe, what else can we do for him?
No, so I think we shouldn't focus so much on viability.
Exactly, yeah.
The reason is there is a very, lot of heart failure and triple vessel disease trials are surgical trials. And there was a particular trial which looked at what about viability and non-viability and the outcome. And they found that whether you considered viable, non-viable, two things were clear. That these patients need to be treated very well for heart failure and revascularized.
Right. So because of his age, I said the question of viability, well, I mean, does it mean that I'm not going to attempt to revascularize?
I mean, the reason I brought this up is because, when you present this to cardiac surgeons, they will say, is it viable? Is it viable?
I wouldn't say that. I mean, our cardiac surgeons will definitely...
Yeah, no, I'm just saying, but in the old days, when
you're talking about
old days.
Old days. And then we had to do a PET, photon and
That's correct. I just got some great surgeons.
I might stop you there. So, I suggested to him, having triple vessel and a poor LV, and I suggested to him that his best option was bypass surgery. What do you think, David?
Yeah, I think that is a good option because you are treating the cause of the heart failure, which is the severe coronary artery disease. And this is also supported by the trial, the STITCH trial, which actually randomized patients with ischemic heart failure with bad coronary artery disease to medical therapy alone compared against bypass surgery. And at the end of 5 years, there was a difference in outcome. At the end of 10 years, there was actually a difference in mortality. There was a survival benefit in those who received bypass surgery
Versus
medical therapy.
Yep.
And in the study, the patients recruited could have viability or no viability. It doesn't matter.
Right.
They should have revascularized surgery.
So anyway, we are running a bit short of time, so I'll move along. Try as I might, right? This guy absolutely said, I'm not doing anything. I'm not doing surgery.
Right.
He refused. And we dragged this out for weeks.
What is his Euro score, David? I mean, what would be the mortality for this guy? For bypass?
I think it's the poor LV function.
Yeah.
That's probably the main risk factor.
Yeah.
5%.
So anyway, he absolutely refused.
I would refuse too.
Would you?
Who wants surgery at this day and age?
Okay, I'll stop you there again. So he declined and we dragged this out. So that was from the beginning of November until the beginning of January last year. This is actually pre-COVID, right?
This is purely on medical therapy.
Yes.
So this is purely on medical therapy, and his creatinine had improved, his BNP dropped significantly, and his ejection fraction improved to 36 just
viable.
on the... Yes. So yes, there you are.
I think this is a very important point. Every time I see a patient with severe heart failure, multivessel disease, the first thing I do is to actually spend time treating them well.
Correct.
So you make all this assumption non-viable and so on, and you can see beautifully how you've improved his ejection
But if
fraction.
we had sent him when he's AF 15, then he
Yeah.
would have high mortality.
High mortality.
Now is the time to do it,
Yes,
isn't it?
exactly.
So he
Angioplasty.
dragged it out.
Angioplasty, agreed.
So we ended up.
Even I can do the angioplasty.
Oh, I'm not so sure about that one.
If you can do AF ablation, you can open up the vessel.
So it was, we did it under anesthetic support. We used a balloon pump. Although by that time, we used a balloon pump because we still assumed that his ejection fraction was very poor.
Yeah.
So although the numbers showed great improvement.
But the studies on balloon pump, correct me if I'm wrong, shows no benefit.
No benefit.
So
Yeah, I mean, again, we all use balloon pump, but when I'm always amazed when the study come out and says no benefit.
no benefit, yeah. So he went through that. It was a very long procedure. And then this is the outcome, right? We did the middle and we did the stage procedure. We did the left anterior descending and the circumflex. And then this happened. So this happened.
Reperfusion?
No, this was in the ward after the procedure, and he was on telemetry. Can you, Razali, what do you think?
You see, the first ECG, I mean, he has, because on the left side, you start from the left side, isn't it? You start from the left side, the top there. Yeah, so it's a broad QRS. If you see on the right side, it's narrow QRS. So this obviously is either we're talking about VT, or but you can see P wave there. The second one, P wave precedes it. And the QRS and RR interval is not very, very regular. So if it's VT, usually it's a bit more regular. So I'm not sure whether this is it's very difficult. I mean, you can show this to 10 people and
AF with bundle branch.
yeah, I mean, it could be atrial tachycardia, atrial flutter with bundle branch, or it could be VT, and then with with the sinus rate going at the same time. That's why you can see some of the RR interval is a bit different, and maybe the QR is different, so you get some fusion beats that comes along. So, but in your case scenario, I would say this is VT. I would just say this is VT.
Unless proven otherwise.
That's right.
But can I ask you here, see, if it was atrial flutter in this setting,
Yes.
again, we've been talking about atrial fibrillation and stroke prevention in atrial fibrillation.
Right.
What if it was atrial flutter?
Okay, if it's atrial flutter, so it's atrial flutter by itself, pure atrial flutter, the risk for stroke is actually associated with a relationship with atrial fibrillation.
Meaning?
So which means atrial flutter by itself has no risk for stroke because there's atrial contraction.
Right.
But the reason the guideline says to give atrial flutter
Lot of it
because of its association with atrial fibrillation.
That means a lot of patients with atrial flutter have coexisting AF.
Atrial fibrillation. Yeah. So we are actually coming to the end of our session. So I'll just slip through this.
Wow.
This is his X-ray post. So he improved a lot. But I want to tell you this one.
This was before the right.
This is before the right. So he came back to do the right
Right.
on the 20th of May.
You need to do the right then.
Yeah, it's quite small. I wouldn't have.
Well, it's large. It's quite large after you open it.
Okay, okay.
But let me tell you this.
Yeah, okay,
The interesting thing. The point is this. The point is this. When he came back for the 20th on the 20th of May, he said, "I should have done the bypass."
Because of the cost.
I should have done the bypass. I can't go through this anymore.
Really?
So, well,
He doesn't know what he's talking
he
about.
doesn't know what he's talking about.
If he had done the bypass, he would have been very upset.
Anyway, yes. So anyway, it's a short, interesting study.
Very nice. Very nice.
Severe heart failure.
Brilliant.
Clinically, often we find the situation where some big name like Razali has labeled somebody's sinusitis. Nobody else would dare to question.
I was going to ask you, what was that just now? The diagnosis, what? Retention sinusitis?
Yes, something's chronic retention cyst or something like that. But of course, by the time they get to see us is sometime, and the signs are gross.
So he was having heart failure, presumably in 2018.
A year.
Already.
A year.
Wow.
So again,
CTOs, this has been going on for
exactly.
some time.
But
So-
they diagnosed him as asthma and sinusitis.
yes.
But to be fair to the diagnosing physician, that little bit of hemoptysis, and it's
Yes.
maybe.
No, and also, by the time a
If they
year.
had done an ECG, they would have seen the Q waves.
But
I don't
if you
think
had seen
ENT
this,
doctors do ECG every day, Razali.
Where?
I don't think ENT
Oh,
doctors
ENT.
do
He saw ENT. That was the mistake.
oh, I've got to stop you guys there again. We have to keep ourselves to the case here. And
He's a
anyway,
very good moderator.
so it's no, but you see, the thing is, by the time he saw me, the symptoms have developed over a year. It was quite gross.
Yeah.
Yes.
So yes, it was easy. It's easy. In clinics, if somebody has said it's a sinusitis, I would treat so as well.
Agreed. Yeah.
So anyway, I think we've had a really fantastic session this afternoon. I hope the audience will give us some feedback to let us know how we can improve. I want to thank Dato David Chew, Dr. Tamil Selvan, Dato Razali, Omar for presenting and discussing such interesting cases, and also giving us giving me especially some clear idea. I think it's about the clinical situation. I think we are very lucky. We are very lucky to work where we are working.
Yes.
Yeah.
I will go across every other day to David's clinic, Tamil's clinic, or your clinic, Razali, and just knock on your door and say, excuse me, can you just look at this?
I think that's the beauty about working at our place.
At
You
our
can
place,
just go and see your friend and say, hey, what do you think of this? So this may not be something that you see in most private hospitals.
Yes.
I work in, both Dave and I are from IGN. That's what we used to do in institution. So when I came to CVSKL, I was very happy to know that we are still working in this environment.
It's unusual, and also for our audience.
Having said that, sometimes we also get lazy. Now I look at patient, complete heart block. Those days I get excited. I want to do now. I say, just call Razali.
Yes.
Pacemaker.
But it's also we can our audience of our audience of medical doctors can also avail of this, because we are easily reachable, and we are happy to look through things with them as well. So with that, I think thank you very much. I hope people have found this useful.
No questions.
No
questions?
I don't know.
Is there any questions?
There's no other questions. We've knocked everyone out already. I want to.
They all only want to ask Razali.
I want to say, I want to wish all our colleagues out there great safety during this COVID pandemic period, and I want to wish them holy puasa that's coming up next week.
Yep.
And thank you again to our audience. Thank you to the team here, and thank you to the great team behind the camera who has made this afternoon really very easy and relaxing. I was quite tense before this, but I'm quite relaxed now. And I want to thank CVSKL and Pfizer for hosting this. And if people find this useful, we'll do it again. We'll do it again.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you for joining us.
Thank you.
Thank you. Thank you for a great
Thank you.
chairperson.
Excellent.